Hello. On behalf of Natus Newborn Care and Peloton Screening Services, welcome to our presentation entitled Congenital CMV, What You Need to Know, featuring Dr. Karen B. Fowler. Dr. Fowler is a professor of pediatrics in the Division of Infectious Diseases at the University of Alabama at Birmingham. Dr. Fowler has been studying the epidemiology, natural history, and pathogenesis of maternal and congenital cytomegalovirus infections and CMV-related sensory neural hearing loss in children for the past 25 years. She has also investigated targeted clinical CMV screening in infants who do not pass their hospital newborn hearing screenings. Dr. Fowler is part of a team of investigators at UAB who've established an inexpensive real-time PCR assay to test for CMV in the saliva of newborns that could be used in large-scale CMV screening programs for identifying congenital CMV infection. Her current work focuses on behavioral interventions to prevent maternal CMV infections during pregnancy. Dr. Fowler was the recipient of the 2015 UAB School of Public Health Alumni Award for Scientific Excellence in recognition of her significant contributions to the field of public health through exemplary professional commitment and leadership. I'd now like to turn the presentation over to Dr. Fowler.
I would like to thank Natus Peloton for inviting me to do this webinar today, and am happy to have you participating with me today to discuss congenital CMV and what you need to know. So many of you probably already know these facts, so let's just review them. CMV is a herpes virus, and it's a very common virus. CMV can infect anyone, but it's not very contagious. So it's going to take the direct contact of body fluids such as saliva, blood, urine, semen, vaginal fluids, or even breast milk in young infants. Most healthy people are not going to experience any symptoms when infected with CMV, and it does not pose a serious health concern. The majority of adults have antibodies consistent with past infection, and for many of us, we do not know when we acquired CMV, but we'll go for a blood test or something and we'll find that we have antibodies to CMV if we're tested for some reason for CMV. And this is also true in young women and in young pregnant women. They often don't know their status for CMV. But where do the exposures come from for CMV, especially for young women? And the exposures to CMV come mostly from young children and also from sexual activity. And what we're going to talk about today is when the fetus acquires CMV from the mother during gestation, the mother may transmit the virus, whether this is her first time ever being exposed to CMV during pregnancy, what we would call, quote, a primary infection, or from a reinfection or reoccurrence in a woman with a previous CMV infection, which we also refer to as a non-primary infection. And this is where women who already have antibodies to CMV prior to being pregnant, and they, for some reason, either acquire another infection, a different virus maybe, or have some reactivation because, as you remember from the facts, CMV is a herpes virus. So CMV occurs 1 in 200 births, 200 live births, and so it's fairly common. So if you look at this graph here on the left, the bottom is the number per 10,000 births, and these are the incidence or prevalence of congenital conditions. You can see that CMV is more common than even hearing loss or some of the other conditions that we test for, such as PKU or hypothyroidism, spina bifida, cleft lip, palate, and Down syndrome. But if you look here, only about 7% of people, men and women, have even heard of CMV, so they're unaware of even that CMV is a congenital condition. And in comparison, that most people are familiar, 65% for spina bifida and Down syndrome, 85% have heard or are aware of these conditions that occur less often than even CMV infection does. And this is from a Health Styles 2016 survey. So how does CMV compare to other congenital infections that women get messaging on during pregnancy? And you can see that CMV occurs much more frequently per 10,000 infants compared to listeria or toxoplasmosis or even Zika that you hear about. In fact, in about 4 million births annually in the United States, 18,000 CMV babies will be born each year, and 4,000 to 5,000 of those infants will have symptoms or sequelae or have some problems after birth due to CMV. In comparison, in 12 million births over 3 years, there's been 167 babies born with congenital Zika in the United States. And in that same time period, we've had 12,000 to 15,000 congenital babies with CMV with symptoms and sequelae. So what kind of messaging do we see if a pregnant woman wants to know about these viruses? What do they find? And so if you go to the CDC webpage, you'll see the response to Zika, and you get the messaging about avoiding mosquito bites, some of the issues about traveling if you're pregnant or thinking about getting pregnant. And if you travel any of these recent years, if you've been in an airport, you'll see the signs that say avoid mosquitoes and kind of warning you about Zika. Also, women get messages about listeria prevention in pregnancy, so they to avoid cheeses, the soft cheeses, and to make sure the cheeses are pasteurized. So again, you see these messaging. And then, and also in toxoplasmosis, you get messages about avoiding cat litter, reducing your exposure to cats while pregnant, and also cooking food. And then we get to CMV, and there's a little less confidence in what we see. It's saying you may lessen your risk of getting CMV, and it talks about the ways to do that is to avoid saliva and urine of young children because they have high amounts of virus in CMV virus in their saliva and urine. And they say that not to share foods, utensils, cups, etc., to wash your hands, and that these cannot eliminate your risk of getting CMV, but may lessen your chances of getting it. And you may say, well, why isn't there a stronger message? I think that's partly because we don't fully understand, just as I said before about CMV and pregnancy. Some women will transmit CMV to their baby, but not every woman who's been exposed to CMV will transmit to their baby. And we don't fully understand what's happening because there may be other causes or whatever. But there's also, in this messaging, the others are things women probably would, maybe you love cheese, but you're willing to give it up during pregnancy. But the other things, such as avoiding mosquitoes or cat litter, those other things are things that we probably all would like to do anyways. But these things that we're asking parents to do or mothers to do are things that could interfere, or people have been concerned could interfere with bonding with their infant, such as kissing the child on the mouth or sharing food and utensils. And so there's been concern that maybe mothers wouldn't want to do this, that this would be too hard to do. And here's just a simpler way. I think the National CMV Foundation puts this forth as simple 5 tips to help prevent CMV, and that's, avoiding contact with saliva when kissing a child, not putting the pacifier in your mouth, avoiding sharing food, drinks, and utensils and straws, not sharing toothbrushes, and also washing your hands after changing a diaper, which hopefully we're all doing anyways. So, but when we've looked at the women's attitudes, Dr. Thackeray has looked at this women's attitudes towards practicing CMV prevention behaviors and found that women had very positive attitudes about CMV. They thought these were things that they could do, that they were feasible, and that they would want to do to protect their newborn. And we did a study on young pregnant women in Birmingham, and we were studying to see if they knew about CMV, which many of them didn't before our study. And we asked them about how many of you are kissing your young child in the last week, on the mouth in the last week. And 40% said that they did this fairly regularly. But after we gave them messaging about CMV and how to prevent it, they had, after 12 weeks, had only 10% reported. So we could see that we could change women's behavior and that they wanted to change their behavior as they were made aware of. And the same was true with sharing food, drinks, eating utensils with young children. They went from 47% to about 15% after being informed and the messaging that we provided. So women are able to change their behavior in pregnancy and are interested in doing so. However, there's another part of this messaging. Also we need to look at CMV prevention messaging for healthcare providers. And a study by Dr. Shan in Australia recently in 2017 showed that most clinicians felt they had an inadequate knowledge about prevention strategies and lacked awareness about transmission routes for CMV. And then another study done by Dr. Muldoon found that only 18% the physical and occupational therapists in the United States demonstrated any understanding of the behavioral modes of CMV transmission. So this is kind of a problem because women like to hear about CMV from their healthcare providers, and if their healthcare providers are uncertain, they're probably not discussing it with their patients. So what can we do? I think there's a two-prong approach that we need to consider and we need to continue to work on. We need to educate women and others in the population about CMV, and also ways to help prevent CMV during pregnancy. And the National CMV Foundation is doing a great job with educational materials that are available, social media, with their infographics that they provide, as well as contacts with other people. You can see the picture in the center of the slide is from Utah, the state of Utah, where they've actually used billboards or on the side of buses messaging about CMV. And so we need to continue to think of creative ways to reach women. Maybe it's short videos, maybe it's on Instagram, maybe it's written materials. It just depends, but some way to message and to reach out to young women and also their partners to be aware. The other area is education of clinicians and other healthcare providers. So how do we do that? I mean, historically, we've done that through scientific conferences, webinars, etc. But does that really reach the busy clinician who has many competing demands on their time? We don't know. I mean, even at scientific conferences, there's competing opportunities to participate in various things that a clinician might be interested in. So we've got to continue to work on that. And I think one area that will help and whether we need to develop, specific messaging to the clinicians beyond scientific conference and webinars, but I think even more importantly are going to be the young women and their families asking questions. So the patient sort of reaching out to the clinician to find information, I think will be very important too, and educating clinicians and other healthcare providers who want to provide the best care for their patients and who would, try to answer their questions and therefore learn a little bit more about CMV. So I'm going to talk a little bit about identifying CMV infections. So, and I'm going to talk about kind of three areas. Approaches to identifying congenital CMV. You may be hearing terms like universal versus targeted screening. Also, is CMV really occurring often enough to need screening? You probably got a hint before that I think it does, but we'll talk a little bit more about that. And then what laboratory tests will identify CMV, and when should we be testing infants? So you hear the term universal versus targeted screening. Well, universal CMV screening is what it sounds like. It's where you screen every baby, in the hospital, or every baby that's born for CMV. And that does not routinely happen anywhere in the United States or elsewhere outside of studies, although Ontario, Canada is going to begin soon, if they haven't already begun, to do this in that province. So some of the reasons it has not been done in the past is until recently there was not really a simple, low-cost, high-throughput test method available. There is one now, so it could be possible through a Saliva-based PCR assay that Dr. Suresh Bobahana developed here at UAB. And then concerns about cost. However, some recent data show that both even targeted screening as well as universal screening can be cost-effective once you get the startup program going. And then concerns about how to manage the identified children who do not have symptoms. So how are you going to manage all these children that are identified? And I think we don't fully understand how that would work. So there was a consensus held in Australia, and it's listed down here below. It was published in the Lancet Infectious Disease in 2017. Bill Rawlinson led the group. And we came up with some recommendations during that time about CMV and pregnancy and the neonate. And one of the things that the group agreed with is that we should primarily consider universal CMV screening because we're going to be able to identify early detection of CMV so we can do early intervention and potentially early antiviral therapy for sensorineural hearing loss and other developmental delay where appropriate. And even we're beginning to see some of the children, some studies are showing that even children without hearing loss with CMV also may have some vestibular dysfunction or some balance issues. So it's important for that. So targeted CMV screening, that's where we select a specific group of infants who are considered at higher risk for congenital CMV infection. That might be the NICU population, which many hospitals will do, or infants who do not pass their newborn hearing screening. This approach is only going to identify a limited number of the infants with congenital CMV infection. And it's sort of like, for those of you that have been around for a little while, the risk criteria-based newborn screening that existed before universal newborn hearing screening, where there were certain risk criteria, and if that infant had that, they were tested in the newborn nursery. However, most infants were not tested. However, that was, as we well know, that was not identifying all the newborn hearing. And so, fortunately, people became advocates for pushing for universal newborn hearing screening, which has now currently been in place for many, many years. So targeted, we don't know much about how well NICU screening identifies infants with congenital CMV infection. We know it identifies some, probably many of the symptomatic babies, but we're not sure, how many others. But we do know from a study that we did with our CHIME study that using the definition of an infant who refers on their newborn hearing screening test to receive a CMV test at that time, that 7% of CMV positive infants did refer on their newborn hearing screen compared to the CMV negative infants, which was about 0.9. So significantly more infants that were positive were referring on newborn hearing screen or failing their newborn hearing screen, so it was important that follow up, obviously, to determine. And what we saw was that about 65% of the hearing loss those that referred, we identified 20 children, and then 15, though, passed. So overall, newborn hearing screening identified about 57% of all CMV-related hearing loss in the newborn period. So although it's not getting all the children, it is beginning to identify more than half of the infants who would have hearing loss at birth due to CMV. And so you might say, why don't we just wait till we know they have hearing loss? And actually that's what the Joint Committee on Infant Hearing recommends at this time. They recommend that or have recommended in the past, so when a child has been identified with hearing loss at 3, 4, or 5 months of age, when you start to look at the etiology of that hearing loss, one of the things they recommend is getting a CMV test. However, that's probably too late because you'll see in a minute that we need to test for CMV in the first weeks of life. So what's the prevalence of congenital CMV infection? So on the right, I have that 1 in 200 live births graph that you've seen before earlier in the talk. And to put it that way, or if you like to think of larger numbers, we have about 38 million births, or 3.8 million births a year in the United States. So that's about 19,267 babies born each year with congenital CMV infection in the United States, using that 1 in 200 live birth estimate. But it's not all uniquely the same. So if we put that 5 or 1 in 200 live births here, the overall infection rates, we do have differences in different racial and ethnic groups. And what we see is that Black infants and multiracial infants have a higher prevalence of congenital CMV infection than what we observe in the white, Hispanic, and Asian. So there's some differences there. And then also another place where we see differences is in the offspring of young women. So here's our overall CMV infection rate of 1 in 200. And what we see here is that teens, Black, white, non-Hispanic, and Hispanic white teens all have higher infection, congenital CMV. Their offspring have a higher congenital CMV infection rate than we see in some of the other groups. And this rate remains high in Black offspring until about the age of 30, where almost all three groups are similar, and probably it's around 1 in 300 there. So there are some differences based on maternal age also. So how do we diagnose CMV? I've kind of touched upon that a minute ago. So we need to detect the virus in the first 2 to 3 weeks of life, and that's why waiting until an infant is confirmed to have hearing loss at 3 months of age, or maybe you'd know sooner, but anyways, it would be beyond 2 to 3 weeks of age. It's important that we have this test done at the early point in life. And so there's two specimens that we recommend. The virus is shed in urine and saliva in large quantities, so those are both good specimens to use to test for CMV or to diagnose CMV. Comments that I would make is serology is not recommended to use. IgM is not sensitive. And then the dried blood spot, it can be informative. So many times an EMT will, in a state that stores their dried blood spots, will request the dried blood spot from the state lab, and then they're able to test the baby blood spot for CMV. And if it's positive, these tests have high specificity, so that's good. We'll be able to know that the baby's hearing loss was due to CMV. However, if the test is negative, the testing currently has a lower sensitivity, so it's not going to be as informative. So at this point, dried blood spot's not the test of choice for identifying CMV. And just to show you, this is some data from our CHIME study that we did of 100,000 infants that we screened for CMV infection. And the screen saliva is what happened in the first days of life when we tested, and then those are the viral load measures. And then enrolled saliva and enrolled urine are what happened about 3 to 4 weeks of age. So you can see that all of them, whether it's in the first weeks of life or in the 3rd week of life, that there's lots of virus in the saliva and equivalent amount in the urine, just to reinforce that message. So for diagnosis, either one of those tests is fine. Most people prefer urine. However, when we're talking about newborn screening and you're doing hundreds of babies, which is best to use, or what are the considerations when you're thinking about doing newborn screening of all the babies in the hospital, or just the targeted screening of babies in the hospital? Well, for both of them, viral load is similar for saliva and urine. You can use the exact same assay, the PCR assays that are used both for saliva and urine. And the difference really is the collection ease and time of collection that does differ between saliva and urine, with urine being more challenging for universal or targeted newborn screening because you're going to have difficulties collecting sufficient amount of urine from the newborn before hospital discharge. You could have contamination. You could have urine leakage. You also have to have a personnel return to collect the bag from the baby at a later time, so at least you've got to visit the room or visit the nursery more than one time to get the sample. Saliva is much easier to collect. It basically takes less than a minute, probably 45 seconds, and just gently placing the swab into the cheek of the infant and just collecting the saliva. So it's not to collect cheek cells, but just saliva. So it's obviously trying to saturate that swab with saliva, and then you easily place it into an empty vial, and then it can be stored over time, either at room temperature for a few hours, or if it's going to be longer than refrigerated. But it can be taken to the lab even the next day and be tested. Breastfeeding doesn't. People have been concerned about breastfeeding contaminating saliva specimens, but breastfeeding does not appear to result in false positive results in the first week of life. So in our study of CHIMES, where we were testing babies within the first 4 or 5 days of life, the false positive rate was 0.03%, so it's very, very low. But however, I think because of that concern of potential of breastfeeding contamination of CMV, is that all positive saliva PCR results should be confirmed by 3 weeks of age by urine PCR. So if you're using saliva for targeted screening or even universal screening, if you're fortunate enough to be in a place that's going to begin that, you would want to confirm the diagnosis with urine by 3 weeks of age. So congenital CMV infection, you can have disseminated disease, and then we also see CNS abnormalities with CMV. So about 10% of the babies born with CMV are going to have some of these symptoms. They may have more than one symptom, but the vast majority are going to be asymptomatic, what we call asymptomatic, or have no clinical signs of infection in the newborn period. That same consensus group that was in Australia in 2015, led by Dr. Bill Rawlinson, looked at sort of defining the definition of congenital CMV infection disease a little differently, because really we know that asymptomatic is just an arbitrary cutoff that we use, but that really CMV disease is a spectrum. And so we have on one end of the spectrum the moderately to severely symptomatic CMV infants who have multiple manifestations. They may have CNS involvement, they could have thrombocytopenia, they could have enlarged spleen or liver, and have many things, concerns, and they may have hearing loss, they may have retinitis. And then we have more what we would call mildly symptomatic CMV, where they may have one or two isolated manifestations that are mild or transient. They may only have an enlarged liver that resolves in a couple of weeks, so those, or they may just have a petechial rash over their body, and that's all that's observed for them. So we would call them mildly symptomatic. We also have what we would call asymptomatic with isolated sensory neural hearing loss. They have no signs of CMV infection, but they do have hearing loss that's observed. And then we have those that are asymptomatic who have no signs, and they also have normal hearing. So those are some of the categories that we use to define infection and disease. And when that becomes important, it becomes in how we evaluate and follow up these infants. So for infants that are symptomatic at birth, obviously they need a thorough physical exam for the growth parameters, for evaluating other signs of CMV infection. They need a CBC, liver enzymes. You want to do neuroimaging to look for cerebral calcifications or other abnormalities in the brain. They're going to need an eye exam and also full diagnostic auditory evaluation. That's beyond the hearing screen. So it's important to fully understand to get some baseline data on their auditory function. Follow-up for these children is obviously age-appropriate hearing testing at least every 6 months until 3 years of age, and some people think even longer. There's been some evidence of delayed onset hearing loss even in early elementary on into middle school. They need obviously some developmental assessments as well as other assessments may be needed depending on the symptoms that the infant has. For asymptomatic infants, those with or without hearing loss, they're going to need a thorough physical exam also just to assess and confirm that they don't have symptoms. They're going to need an eye exam at some point. In a recent study that we've done, we didn't find any asymptomatic infants with retinitis, so maybe the eye exam could wait. It doesn't have to be done before hospital discharge. And they also are going to need a full diagnostic auditory evaluation, not just a hearing screen. And then because they're at risk for late onset hearing loss or even progressive or further deterioration of their hearing loss, they're going to need routine follow-up also. And the question is for how long and whether to do it annually up through adolescence, because we have seen some late onset hearing loss occur at 8, 9, 10 years of age. And then questionable whether they need developmental screening assessments. And we're uncertain about that completely, so that's why there's a question mark as to whether that needs to be done. So the consensus recommendation for treatment for CMV. So the symptomatic, the moderately to severe symptomatic infants are the only group recommended for treatment because they're the only population in which there's a randomized controlled data providing benefit. And that's the recommendation of 6 months of oral valganciclovir. That treatment should be initiated within the first month of life, and they should be monitored for neutropenia, obviously, and any other adverse events that may occur from treatment. And the treatment duration is for 6 months. This is what the consensus recommended. Then the consensus made the comment, the group said, antiviral therapy is not routinely recommended for mildly symptomatic infection, nor is it routinely recommended for asymptomatic infants with isolated sensorineural hearing loss. And the reason it said not routinely recommended is that there's no data in these groups. So this becomes a decision that's made with the doctor and the patient, or the doctor and the parent. And so there are children that are treated that have mildly symptomatic, and there's also children with asymptomatic CMV with isolated sensorineural hearing loss that are being treated. And those are just decisions that have to be made on a personal level because the data is not completely there. At this point, the group said it's not recommended to treat babies with asymptomatic CMV and no hearing loss. So they have no symptoms and no hearing loss, and so it occurs. The good news is, even though we don't have data in these groups, there are 2 current ongoing studies in the United States that are clinical trials. One of them is going to look at children who refer on their newborn hearing screen, who are asymptomatic and refer on their newborn hearing screen and are determined to have hearing loss. They're going to be treated with valganciclovir for 6 months, and that's being led by Dr. Albert Park in Utah. And so we hopefully will have some data in the next few years to answer that question. And then there's another study that's going to treat asymptomatic babies without hearing loss, and that's being led by Dr. David Kimberlin here at UAB. And so hopefully these 2 trials, clinical trials, will give us more data and provide us more concrete evidence of the impact of valganciclovir as an antiviral treatment for CMV infection. So why that becomes important is because that both symptomatic, about 40 to 50% of them are going to have hearing loss, and then also 10 to 15% of the asymptomatic infants will have hearing loss. The asymptomatic infants can have some cognitive impairment, though less than what we see in symptomatic infants. And there are, data that suggests that 1 to 3% may have retinitis. That may be a little high, depending on the populations that have been studied. But it's more likely that you'll see eye involvement or eye lesions in symptomatic infants, and also we see cerebral palsy many times in infants with symptomatic CMV infection. So hearing loss, sensorineural hearing loss at birth, we've seen in our recent data from the CHIME study was about 8.9% for the overall cohort, and then with late onset it went to 12%. So similar to what I just reported, the 10 to 15% that we've seen. And this is the reason I have underlined in yellow, not based on hearing screen refer fail, is to make sure that this is based on a diagnostic audiology evaluation, because we all know that a newborn fail needs to be followed up just to confirm that it's not a false positive that's been observed. So if we look at the burden of CMV infection in the United States, I'm using the 3.8 million births, it's the most recent data that I could find, and the 1 in 200 live births. We'll have about, in the symptomatic children, we'll have about 1,100 children that will have disabilities, will have hearing loss, can have other issues. And we also have a large number of asymptomatics that we're identifying. However, that large number, even though fewer of them have hearing loss or other disabilities, is still a larger number than even the symptomatic infants, with 2,600, for a total of 3,700 infants annually that have CMV-related disabilities. And so when you think about that, that's probably about 10 children per day, or if you think in decades, that's 37,000 children that are going to have disability and have potentially hearing loss and other issues due to CMV in the United States. So in summary, approximately 1 in 200 babies in the United States will be born with congenital CMV infection. It's the most common congenital infection. We're going to see if you're in a population and in an area where there are more black infants being born or young women are delivering infants, those are going to have higher rates of congenital CMV infection than you're going to see in white infants or Hispanic infants or infants of older women. So there are differences that we observe in the United States. And CMV is a leading cause of permanent hearing loss in infants and young children. It's second to genetic causes, and so it's a very important cause that we need to identify for management of these children. And at this point, the best method is the Saliva PCR for screening if you're doing either targeted or universal CMV screening. It's a highly sensitive and reliable method that's able to identify congenital CMV infection. Recommended screening for congenital CMV for any newborn who refers or fails on newborn hearing screening, whether the screening is unilateral or bilateral, especially when the etiology of possible hearing loss is uncertain or unknown. I think this is time to consider, and I think not every hospital is doing this, but more and more hospitals and states are considering this approach. And then CMV awareness and knowledge of CMV prevention are needed for the general population, but also for healthcare providers. And I just want to end here a little bit with the National CMV Foundation, and the address is there on the bottom of the slide, where they provide quite a bit of information about CMV and sort of provide a clear warehouse, I guess, of information. They have things such as this picture here that you can download. Their goal is to inform and engage and advocate for CMV. And they do that through both their information education and then working with parents and parent groups in different parts of the country on CMV legislation. And so you can see here, this was just an updated, it always is changing in October, but the cyan, the dark cyan-colored states are states that have actually had screening or education laws enacted in their states. And the light green are states that are currently have laws proposed. And you can see the gray are states that have stakeholders interested in pursuing legislation. So it's an ongoing process and it changes. And I think just in the last month, New York State just signed a targeted screening approach and education approach for CMV for the state of New York. And just to end, I'm here in Birmingham, Alabama, and I invite all of you to come join us for the CMV 2019 conference. This is where scientists and clinicians come from all over the world to discuss CMV, and it's not only to discuss congenital CMV infection, but they'll also be discussing CMV and transplant patients, as well as immunology and virology. But we have specifically focused Sunday afternoon the 7th through Tuesday lunch on congenital CMV infection and have offered special rates for other healthcare professionals who would like to come, as well as special rates for parents who would like to participate. So we hope to see you there. So on that, I will end, and thank you very much for taking time to participate in this webinar, and hope it's been informative to you. Thank you.